Dear attendees, good morning. FOCP is honored in collaboration with Max Healthcare to introduce Dr. Akshay Tiwari, consultant oncologist, to present an awareness session about bone cancer treatment and prognosis. Dr. Akshay, thank you so much for being on board today with us. Please go ahead. Thank you so much.
Thank you. Thanks a lot for having me and giving me this chance to share some of our work on bone cancer. And I'll just start by saying that you would all know bone cancer is one of the rarest form of bone. Basically, two types. One is a primary bone cancer, which starts within bones, and it's called sarcoma. And the other, which is a secondary bone cancer or metastatic bone cancer, which is cancer that starts in the other parts of the body, for example, the lungs, the kidneys, and other visceral organs, and then affects the bones secondarily. So today we are going to talk largely about primary bone cancer or bone sarcomas in general. A lot has changed in the last maybe a couple of decades in the treatment of bone cancer. And while initially most of these patients were undergoing amputations, a large majority, more than almost 90% or more, are now undergoing limb-saving surgeries. And a lot of things have contributed to these advancements. So as I said, we are largely going to talk about sarcomas of bone and something about soft tissue sarcomas as well, which go hand in hand as far as the treatment principles go. So the steps, as for all cancer, is diagnosis, staging, and then definitive treatment. The diagnosis will involve a history and exam, lab investigations, imaging, which largely depends on X-rays and MRI for the local part, and metastatic workup, and obviously histopathological examination in terms of biopsy. We always say that the surgeon himself, preferably at the center where limb salvage surgery is routinely performed, the biopsy should be done. It has to be in line with the planned incision. Therefore, you need to know and you need to be a center where limb saving surgeries are routinely done in case you want to embark upon doing a biopsy for a bone sarcoma. We usually nowadays do a core needle biopsy. It is simple to do, gives you adequate material. It can be done in an OPD setting under local anesthesia, so saves a lot on the cost as well. So open biopsies are only very rarely done in some select cases. For example, this patient, a bone sarcoma of the femur, and we can see a large soft tissue component. We can actually just take the soft tissue component with a true cut biopsy as we would do for any soft tissue cancer. Or in case of a purely bony lesion, we could use a Jamshidi needle for a biopsy. So look at what has changed from open biopsy, which was done a couple of decades back. We now moved on to core biopsies. Most of patients are having limb salvage surgery. What we are doing now is modular prosthesis. We are using a lot of recycled tumor bone, as we'll see as we go along. Allografts and vascular autografts are also used a lot. Even spinal and pelvic sarcomas, we are now looking at curative unblocked resections. So whereas amputation was used to be the standard earlier, it's now limb salvage, where you remove the cancer, replace or reconstruct the limb in some form so that it retains not just its form, but also its function to the maximum extent possible. The plan remains of complete evaluation, neoadjuvant chemotherapy for most bone sarcomas, most commonly osteosarcomas and Ewing sarcomas, and then resection with wide margins. We'll understand what this means, then optimal reconstruction, and then further chemotherapy. Usually that is how we go about. When we look at a sarcoma affecting a bone, we know that it's not just a tumor, but also these satellite nodules, which are lying in vicinity of any high-grade sarcoma, and which is why we are looking not at an intralesional or a marginal margin, but a wide margin, where we are cutting not through the tumor, not through the capsule of the tumor, but through normal tissue. So just to understand, if you start cutting piecemeal like this, it's called an intralesional margin. If you cut through the capsule, it's called marginal margin. If you're cutting only through normal appearing tissue, it's called a wide margin. This is the kind of surgery we usually do for bone sarcomas nowadays. An even wider margin is called radical margin, where you remove the whole organ and not just the tumor with wide margins. Once you have done that, we see that after your wide margin is done, you have to reconstruct the defect in some way so that the limb can be used by the patient as he was using before the surgery. It has been proven, not now, but since 1980s, that limb saving surgery, if done with the right principles and along with the adjuvant therapies, the survival is just the same. It's not as if amputation guarantees a better survival chance to our patient. So which is why limb salvage surgery has really caught up in the last couple of decades. When we look at, once we have removed the tumor completely as discussed with the principles, the optimal reconstruction may be, if you are lucky, you may not require any reconstruction for some bones like the fibula, or you look at a prosthesis, which is a non-biological reconstruction, the most commonly used, or sometimes biological reconstruction where you use some kind of a bone, and we'll see how. So ultimately, it's a balancing act. You have to have complete cancer removal, but at the same time, to retain optimal function, you do not want to remove too much. You want to remove just the amount that you need for a curative surgery. So as we discussed, if it's a sarcoma of the fibula, we just need to remove the sarcomatous bone, the cancerous bone, and we do not need to reconstruct. Similarly for ribs and clavicle and certain other bones. But if it's a bone like a distal femur, a prosthesis is the most commonly used method of reconstruction. This surgery was done in 2009, and this patient is still going strong, free of disease, and walking well on that prosthesis. Similarly, this patient who underwent a proximal tibia resection and replacement with a megaprosthesis, this was back in 2010. He is also doing well, continuing with that prosthesis and still free of disease. What happens if whole bones are contaminated by disease due to some, for example, here an intramedullary nailing was done, so the whole bone got contaminated with sarcomatous tissue. What you need to do here is to replace the whole bone, not just the part affected, but the whole bone, because there is nail which is carried cancer cells all along the bone. So this is called total femur replacement, and this is what was done for this lady again in 2011. So again, 11 years, and she's managing well with that implant. She had a chondrosarcoma of the femur. What's an expandable prosthesis? If it's a child where you need to balance the limb length at the end of skeletal maturity, once you have removed one part, a growth plate, because it was involved with cancer, you are worried that once the child grows, he will have a discrepancy of limb length. And here you can see it's a prosthesis that can be lengthened with time. This one is a minimally invasive one where you need a screwdriver, a small surgery every time you need to expand. But then there are prostheses which are non-invasive, where you just put them in a magnetic field and they expand on a regular basis. Again, one more patient. Look at this patient who was operated in 2009, again a distal femur osteosarcoma. And he's now, this is about a few months post-operatively, and we see what happens. About 6.5 years post-operatively, he was a young, active man. He underwent aseptic loosening. We can see loosening happen in this prosthesis, but that doesn't end the world for him. We can again revise that implant. It was revised in 2015, and this is in 2022. He's now the father of a child. He's married and doing well with a government job. We've also learned along the line that biological is logical, and for example, this patient who was treated for an osteosarcoma of distal radius, treated with a vascularized fibula graft, and this is where a very good plastic surgery backup comes in very handy. And you can see excellent hand function. She had good pronation and supination as well. Again, a growing proximal fibula can sometimes replace the proximal humerus in a young child who has got growth potential. And this is where we used we had to remove this proximal humerus for osteosarcoma and then replace it with a growing vascularized fibula with the growth plate along. And we could demonstrate that some lengthening did happen for this child. And we also published the results of vascularized fibula graft. We combined this with extracorporeal radiation, which we'll come to in subsequent slides. Again, if it's an intra-articular resection, if we have to remove the whole joint along with all the muscles, we still can arthrodese a joint. And this is where a joint fusion was done after complete cancer removal. So even if the joints are invaded, we still have some answers. A parosteal osteosarcoma, which was involving the femoral neurovascular bundle, again, a good vascular surgery backup makes sure that we can still salvage these limbs, even if the vessels are involved. A vascular graft was placed and a limb could be salvaged. Sarcomas of spine, again, while earlier the norm used to be just piecemeal removal, but now we know that some sarcomas of spine can actually undergo unblock resection with wide margins. And again, we can offer curative surgery. This chondrosarcoma of spine was removed unblocked and with good margins. What about pelvic osteosarcomas or pelvic bone cancer? Again, this young patient, this was again back in, I think, 2012, when he had an osteosarcoma of the pelvis. He was told he's going to probably not survive because, location, but he was given neoadjuvant chemotherapy. And he was also told that, okay, but probably you'll lose the limb and half of the pelvis. His limb could be saved. And that is how he was walking about 2 or 3 years after surgery. There was some shortening, but then he's able to do all his day-to-day activities. He also had undergone chemotherapy, because of which infertility was a definite possibility, which he was apprised of. He was told probably you'll not be able to become a father, but then this man would not stop. And this is how he is today. He's married with 3 kids and he's still going strong and a good friend. So as we go along, we keep asking ourselves, does conservative surgery result in survivals that are equivalent to amputation? How long does the reconstructions last? How can we improve our results? In short, is it really worth it? We looked at internal hemipelvectomy, where we remove half of the pelvis back in 2013, and we could see out of 25 patients, 2/3 were actually free of disease at the time of evaluation. We also have been evaluating our results of osteosarcoma and Ewing sarcoma, and we could see that even though we could see the 3-year survival was 61% in osteosarcoma, similarly for Ewing's. So we could see that our survival rates, not just limb saving rates, but also survival rates, kept on improving as we went along and could actually match the world literature. We also got to see and use certain innovative methods of reconstruction. For example, if we want to have a bone replacing a bone, we could use the cancerous bone, take it out of the body, make it cancer free by some means, and then reimplant. Look at this child who was 10 years when he underwent surgery in 2012, and we removed this Ewing sarcoma. We could remove completely and send it for radiation under this machine. After radiotherapy, it became cancer free, and we reimplanted. Look at what happens as we go along. This was 4 years after surgery, and this child was running like he is. This is something that we will not have the confidence of if we use a prosthesis. Then 8.5 years post-op, he's still going strong. He is in his high school or past high school, and the bone is still strongly very much there. Again, 10 years post-operatively, he again comes to us, again cancer-free, thankfully, and the bone is still strong enough for him to carry such activities. He's now an engineering student. Another way of recycling cancerous bone is cryosurgery, which is a new kid on the block, where we have started not using radiation, but using liquid nitrogen to freeze the bone, make it cancer-free. Like in this child, we could remove the bone, dip it in liquid nitrogen, and then replace it back and save that leg or save that hand from amputation. Again, one more patient where we had to remove this bone for Ewing sarcoma of bone. And after removing, we could isolate this bone away from the rest of the limb, dip it in liquid nitrogen. This is what we call cryosurgery and reimplantation. And then we put the bone back again. We can see the frozen bone here. And then after it is cancer-free, it was placed back into the defect. And in 2 months, the bone started healing. So that's the advantage. We also evaluated our own results, and this was an award-winning paper by our fellow Dr. Akriti. 39 patients were evaluated, out of which 31 patients were disease-free. And we could see that if we use liquid nitrogen, we could achieve healing of bone much faster. And so these patients were able to be rehabilitated much earlier. What more, we kept asking ourselves, for example, this child who was 8 years and had an osteosarcoma of the proximal tibia, he was a candidate for amputation, but an innovative method, which is not our innovation, but has been used for decades, but is done only at specialized centers where you remove the middle part of the bone and then reimplant the bone up, but only after rotating the foot backwards. So now the ankle of this patient now becomes the knee. And instead of an above the knee amputation, he now acts like a below knee amputation. This surgery is called rotation plasty. And this is particularly beneficial for poor patients who cannot afford expensive prosthesis, expensive expandable prosthesis. And this child, as you can see, is having a good time mobilizing and playing. What about soft tissue sarcomas? Multimodal management is the backbone. We have very good sarcoma medical oncology and radiation oncology teams, which come in very helpful for such patients. For example, this synovial sarcoma of the pelvis, wide excision, chemotherapy, and radiation. Again, soft tissue sarcoma, which was involving the femur, we could remove not just the soft tissue, but also the bone and replace with a prosthesis. Again, soft tissue sarcoma in the groin, if the vessel is involved, we can actually put a vessel graft and again get away with a wide margin. Again, a soft tissue sarcoma of the axilla, who was advised amputation because of the involvement of the brachial plexus, we offered preoperative radiation, shrunk the tumor, and we could again have good margins and also had median nerve repair. And that's the kind of function he now has. Otherwise, he was going to land up in amputation. So this patient is now 1.5 years post-surgery and doing well. We evaluated our results and we could see that 73% was the survival rate at 5 years in our patients with soft tissue sarcomas, all kinds included. We also had this paper again, which was an award-winning paper at NatCon, where we looked at the size of soft tissue sarcomas and how they led to the results and outcomes. We've also seen that technology really helps. 3D printed jigs have been used for more precise cutting. For example, a child like this with an osteosarcoma of the distal femur, where we can make precise cuts using a 3D printed guide to guide a drill. That's the jig. And that's a model of the bone. We can see that we can place it just at the place where we want to make that cut. Not just 3D printed jigs, we have also been using 3D printed implants, especially for situations like a young child where you do not have ready-made plates or prosthesis. You can use the 3D printing technology using the CT scans and then make plates which can fit exactly the size of the bone in question. Another technology that has helped us really, particularly in cases involving the pelvis or the sacrum, where look at this sarcoma of involving the pelvis in a young child. He was 7 years. If you make a cut blindly here, you could end up injuring that vessel, or you could end up injuring that nerve root, or you could actually enter the tumor. All these are situations which you do not want. What if you can precisely place these cuts and cut exactly where you want? And this is where this piece of equipment called computer navigation has come in very handy for us, where we could, for example, this child, the same child that we saw the MRI of, is having an Ewing sarcoma of the pelvis. This is the tracker that helps us place our instruments precisely at the place that we have planned before surgery. That's computer navigated tumor surgery undergoing and that's how we place our instruments, and we on the screen it shows where exactly we are making our cuts, so that we can have that sub-millimeter accuracy when we have to cut adequately and at the same time save critical structures. Another example where GCT of the iliac blade was operated on using computer navigation. We can see we have not got much of a margin here because we have to save the nerve roots. We are very critical for the limb function, and at the same time remove the tumor completely, and that's the result. We also published our early experience of computer navigation recently. We've also seen that certain things have to be kept in mind. If you're not a bone cancer surgeon, you need to know that there are certain things you need to be aware. We all as doctors need to know that bones also can have cancer. And incidentally, July is Sarcoma Awareness Month, so this lecture is quite well timed. We all of us should be aware, particularly orthopedic surgeons, and any physician who sees a lump or a mass in a bone or a limb which has more than 5 centimeters, or which has been increasing in size over time, again, which is deep to deep fascia or painful. Any one of these warning signs, you must think that it could be cancerous and get it checked by a specialist before just writing it off like as a, say, a lipoma or just a tuberculosis of bone, or just saying that it could be just a hematoma. So these are the warning signs we need to be aware if we want to pick bone cancer and soft tissue cancer early enough. Again, don't mix biopsy with fixation. This is for orthopedic surgeons. Don't biopsy if you're not sure. As I said in the beginning, anyone who biopsies a bone sarcoma or a soft tissue sarcoma should be aware of limb salvage surgery, and only then embark upon a biopsy as a procedure. So the sequence has to be careful clinical evaluation, imaging study analysis, and then biopsy. It cannot be the other way around. Again, the jigsaw of clinical, radiological, and histopathological parameters have to match. We just cannot rely on purely on biopsy. Clinical and radiological correlation is absolutely necessary if you want to avoid disasters and mistakes. We've also known that we need to collaborate and connect. Indian Musculoskeletal Oncology Society was founded about 4 to 5 years back, and we've also had Delhi Musculoskeletal Oncology Group, and we have collaborated with NGOs where they have helped us in surgeries for kids, underprivileged kids with bone cancer. We've had musculoskeletal oncology fellows also coming out of the department and doing well wherever they are. We have had meetings, conferences on orthopedic oncology. But what really keeps us going is our patients. This patient is, both of them are rotation plasty and osteosarcoma survivors, and have this particular boy has traveled far and wide to raise awareness on bone cancer. Another patient who is now an artist and a singer, he's also an osteosarcoma survivor, and that's a sarcoma clinic, and that's her team, because it's only with the good team that you can carry on this work with such quality. Thanks a lot, and I'm open to any questions that you may have.
Thank you so much, Dr. Akshay Tiwari. We will see if anyone, the attendees, if they have any kind of a question. So the slot is open for them.
Yeah, any questions from any of the participants?
No, there is no questions. And so, Doctor, of course, this video will be, or the session will be uploaded on our FOCP YouTube channel. I will share the link, inshallah, later on with the team. And if there is any concerns from the viewers, I shall forward it to you. So in conclusion, I would like to extend a special thanks to you, Doctor, for this valuable lecture and useful information. And we hope for more fruitful cooperation in the future, inshallah, in providing whatever serves the community. So thank you so much, Dr. Akshay. Thank you, Max Healthcare, for your support.
Thank you. Thanks a lot, Jamila, for having me. Always a pleasure.
Thank you, Doctor. Inshallah, see you soon in other topics, inshallah, and other awareness webinars. Thank you.
Sure. Thanks a lot. Bye-bye.
Thank you, Ms. Jamila, once again for giving us the opportunity.
Thank you, Maria. Thank you, and wishing you, inshallah, to see you in the future, inshallah.
Inshallah, ma'am. Take care.
Take care. Bye-bye.
Bye.